Good afternoon, everybody, and congratulations to Gore for 50 years and for that kind introduction. We're just chatting. You probably got that off ChatGPT. Anyway, so I guess our session today is called Dialysis Access Decisions where Data, Guidelines, and Patient Align. So what I'm going to talk about is discussing the data, some myths versus facts, and the data underlying the guidelines. I'm going to talk about some of the KDOQI guideline concepts as they relate to choice of vascular access and managing AV graft complications. Within this, I'll talk about some novel tools to help align access choice and patient needs. So my mother always told me, keep an open mind, myth versus facts. And since you're eating lunch, I'm going to bring up a Canadian concept, and that is poutine. So who knows what poutine is? Okay, so has anyone had poutine? So people say poutine is disgusting, and when you think about listen to the description, it's French fries, cheese curds, brown gravy, and something else. And it sounds absolutely disgusting. But the fact is that everybody loves poutine, okay? So that's something that you've learned about Canada. And I've learned something about the United States. And everybody knows that the Declaration of Independence was signed on July 4th, correct? Right. So we're all nodding right. But in fact, it's a myth. The fact is that Congress approved the final declaration on July 4th, but it was actually signed on August 2nd. So what I'm trying to get to is that there's myth and then there's facts. And what I'd like to talk to you about is myths and facts in vascular access. So one of the things that we've always been taught is that fistulas are superior to grafts. And what I want to do is delve into that and examine where that initially came from. And so here are some things that make fistulas superior to grafts. Fistulas have superior survival. They last longer. Fistulas have fewer complications. Fistulas require fewer interventions. Patients with fistulas incur lower access-related costs, and fistulas are associated with lower mortality compared to grafts. Now, does this all ring true to you? Right? Yes, so this is what we've heard. Okay, let's talk about the first one. Fistulas have superior survival. They last longer. So this is where that data initially came from. It was the data from Steve Schwab where he got a lot of information together, and I want to point out to you that this was done in 1999. And as you can see here, along the top, you can see that fistulas in red are superior for both primary unassisted patency as well as cumulative or secondary patency compared to grafts, which are in the dotted line. So this is where the data came from that said fistulas have superior survival compared to grafts. But one thing that people missed was the fine print. Everybody misses the fine print, and the fine print says that AV fistula patency excludes fistulas that did not mature sufficiently for initial cannulation. So those fistulas that did not mature were excluded from this analysis. And when you look at this analysis, including that exclusion, this is actually what it looks like. But you can see that the lines cross. So that is not only true for that initial data, but also other data. So this is data that I looked at. I looked at over 1,100 first vascular accesses with fistulas looking superior in the dark black line, with grafts looking inferior with the gray line. But when you exclude fistulas that failed, that's what it looks like. But when you include fistulas that failed, you can see that there is no difference. You can see that this is the case with forum accesses only, where if you excluded fistulas that did not mature, that it looks like it's superior. Whereas if you included fistulas that failed to mature, there is no difference. When you look at upper arm accesses, there is no difference, regardless of whether or not you include or exclude fistulas that fail to mature. I'm not the only author that showed this. There's other authors that demonstrated this. And I guess you would say, well, this is just observational data. This is not being shown in a randomized clinical trial. But in fact, there has been a randomized clinical trial, and actually there are some that are ongoing right now. And this RCT looked at fistulas versus grafts. And when you compare fistulas versus grafts in a randomized clinical trial, we actually found that grafts were superior to fistulas. And that is for both primary patency and secondary patency. And in fact, the patients with grafts were actually older, 62.5 years, compared to fistulas, on average 57.6 years. And patients with grafts actually had more significant comorbidities that would make them likely to fail, such as having more ischemic heart disease and peripheral vascular disease, yet they still had superior survival. So again, I just want to debunk that myth that fistulas have inferior survival, because when you look at observational data as well as an RCT, that was not the case. So this study concluded that patients with poor forearm vessels could benefit from a graft vascular access. So the second myth, or reason that we think fistulas are superior, is that fistulas have fewer complications. So one of the key complications that we think about is infections. We're always worried about putting grafts in our patients because we're worried about increased infections. So this was a study done a long time ago, but it still has the highest numbers from USRDS. And they looked at close to 180,000 prevalent patients and 11,000 incident patients. And you can see that the infections or sepsis per year for patients with fistulas and grafts were very similar and much lower than those patients who had catheters. And this was the case for both incident as well as prevalent patients and accesses. So you would say, this is really old data. What about more recent data? And this data was published last year in CJASN. And indeed, fistulas did have a lower infection rate, but it wasn't the magnitudes greater than we typically think about, like 6 or 20 times more. It was only about 2 times more, and both were significantly lower compared to a catheter. So that's one important complication that we think about, but there's other complications. So when we think about fistulas and grafts, they each have multiple complications and each more unique. So fistulas tend to have more issues with fistulas failing to mature or non-usability, whereas grafts have more stenosis and thrombosis. And when you put them all together, you need to think about, when do these complications occur and what does that actually translate into? So when you look at the time from creation, fistulas tend to have more complications of failure to mature usability, whereas later on, grafts have more complications of stenosis and thrombosis in that maintenance time frame. But on balance, in order to correct those complications, they need intervention. So along the lifespan of that access, they probably have equivalents in terms of interventions to maintain their patency. With those complications, there's also catheter use, and that probably balances out the same as well. So what about patients with fistulas incur lower access-related costs? Is this true? So there's a lot of analysis that have been done, and when we think about it, we need to think about all of the reasons why there are increased costs: interventions, catheter use, complications. And this was one of the first studies that looked at this. This was a very comprehensive study looking at initial fistulas versus initial grafts. And they got cost data from outpatient visits, inpatient visits, thrombectomies, treatment for sepsis, hospitalizations, excisions of infected grafts. And they also looked not only at databases, but they actually got actual quality of life questionnaires, and they determined the qualities. And if you look at this table, the average cost for a fistula was $16,151, and the cost of a graft was actually a little bit less. And the quality gained for a fistula was only 0.13, so very little gains. And these authors concluded that fistulas had better cost utility only when the maturation rate was greater than 69%, and that fistulas cost less only if the maturation was greater than or equal to 82%. Yet we heard this morning that many fistulas have a higher failure rate than 50%. Moving on, there's been a lot of different cost analysis, and I don't have time to talk about this, but this was a recent publication looking at real-world costs in contemporary times. And so what they looked at was patients who started dialysis with a catheter. And in the United States, 80% of our patients start dialysis with a catheter. Then they looked at what happened after that, if they went on to have a fistula, a graft, or a catheter. And then they looked at the costs associated with this. Along the y-axis is the median annual cost. The black is the fistulas, and the gray is the grafts. And fistulas had new access creation, they had more surgical revisions, they had greater total access surgeries, and the cost per year was close to $11,000. Grafts, on the other hand, had more thrombectomies, but they had a lower cost of $6,800. Fistulas and grafts had similar total percutaneous procedures, catheter-related bacteremias, and related hospitalizations. And so this excess cost for the fistulas was really driven by fistulas that failed to mature, which is approximately 36%. And fistulas that fail to mature or to be used cost about 2 times more than a successful fistula. And if a fistula was successful, the cost was similar to a graft. So the last myth is that fistulas are associated with lower mortality compared with grafts. And there's a lot of data that I can show you, but I don't have time. So I'm just going to summarize and say that there are many studies comparing vascular access types and outcomes, and they're blemished by a lot of bias. And this study demonstrated that bias. So this study looked at close to 4,000 citations, looked at 67 articles, and on the red is indicating moderate to high risk bias, and along the y-axis are the different types of bias: participation bias, selection bias. Look at the huge selection bias, measurement bias, confounding bias, and analytic bias. So when we think about are fistulas superior to grafts, I would say yes, in many situations they are, especially when you have amazing surgeons like John Lucas, who follows his data, Tip Jennings, number of excellent surgeons here, Dr. Shenoy and others. But in the real world, we may not have that, and we can't really apply that fistulas are superior to grafts in all of these situations. As I've showed you, the fact is, when you look at the data, that's not always true. And so based on this, the KDOQI guidelines indicated we need to take another look at this, and we can't have a one-size-fits-all given that data. And we really need to look at the right axis in the right patient at the right time for the right reasons. And that's when they said that really there is inadequate evidence that I showed you to really recommend a specific type of vascular access for everybody, and that we really need to base it on other things other than vascular access complications and hospitalizations or mortality, because as I've shown you, the data isn't rigorous enough. So what they suggested was to have a fistular graft in preference to a catheter in most cases. And so I think the circumstances and the timing really matters. So in the guidelines, they talk about which access for which patient and in which location. And so here are some examples. If a patient has this planned start to dialysis and they have a long expected life expectancy, then maybe you should have a forearm fistula. However, if they have a planned start and they have limited life expectancy and you don't have the time to gain the benefits of having a fistula, particularly with interventions that may be required to facilitate maturation, then maybe a forearm loop graft might be better. Or if there's an urgent start and a short life expectancy, then maybe an earlier standard cannulation graft. If they have an urgent start, but they have long life expectancy, then maybe you have time to think about other modalities, such as peritoneal dialysis and a PD catheter. And then if not, maybe you want to preserve your central veins for future AV fistulas and put in a forearm graft so that the blood flow can improve the upper arm access, so when that forearm graft becomes problematic, you have clear central veins and a nice vein to create that fistula. So it's really thinking about a lot of permutations and combinations, thinking about the patient at the core. So our patients is what we really need to think about, and when we think about our patients, many of them will need to have a fistula, catheter, and a graft in their lifetime, and that is when we need to think about the access life plan. So how do you choose what is best for your patients? The guidelines say that the choice of a fistula graft is based on the operator or the clinician's best clinical judgment, and you need to consider many things, not just the vessel characteristics, but their comorbidities, their health circumstances, and their patient preference. So how do we really do this? So I'm going to give you an example and share with you an example of how we might be able to approach this clinically. So here is a 48-year-old woman, has diabetes, hypertension, atrial fibrillation, She's highly functioning. She works as a child care worker. She's left-handed, lives alone. She's obese, and she's had many prior venipunctures. The quality of her veins aren't perfect. She has a damaged cephalic vein of 1.5 millimeters. She has a good basilic vein of 2.2 millimeters, poor radial artery of 1.6 millimeters. And she presents to the emergency room because she's got uremic symptoms and she has a really elevated serum creatinine. So she needs to start dialysis urgently. And in this patient, PD is not an option. So one of the things you can do is you can go to the KDOQI guidelines and look at their algorithms. So there's algorithms to think about. And this is an algorithm of a patient who is pre-kidney replacement therapy being considered for hemodialysis. And I'm not going to go through this algorithm because it looks really complicated. But again, I want you to look at the fine point. So the fine print here says you may use an app. So there is an app that was created that could be helpful. It's available on the website, and you can also download it on the Google Play Store if you have an Android phone, or on the App Store if you have an iPhone. And there's two components of this app. One is the clinical situation algorithms, and it actually walks through all of the KDOQI algorithms. And then the other one is the vascular access selection assistant that talks about the appropriateness of the choices. So let's walk through this, the clinical situation algorithm. So in this situation, the patient is pre-kidney replacement therapy or pre-dialysis patient who's being considered for dialysis. What is the likelihood of long-term survival? So she's young, she's active, she has very good likelihood of long-term survival. Is this patient appropriate for an AV access, or is this someone more appropriate for a catheter? Well, of course this patient is appropriate for an AV access, and I'm skipping over the small fine notes that you should read when you're making these decisions, but yes, she is appropriate. And in this situation, is she a good fistula candidate? Well, given the urgency, her poor vessels, probably not. So then the algorithm will say, well, this patient should probably have a graft. And so the next step you could think of is, okay, that's what the KDOQI algorithm tells us, but is there any scientific data to support this, and how appropriate is this? So then you could go back to the vascular access selection assistant, and there is a lot of science that went behind this that I don't have time to talk about. It's been published and it's been condensed into this app. And so going to that part, you're going to be asked a number of questions about the patient's characteristics. And the first question is, how old is this patient? This patient is 69 years old or younger. What is her need for dialysis? It's imminent. What is her functional status? She's fully independent. And then it'll ask more questions about her anatomy. Is she obese? Yes, she is. What is her cephalic vein like? It's poor, it's less than 2 millimeters. What is her basilic vein like? It's intermediate. And what is her radial artery like? It's poor, it's less than 2 millimeters. And with that, it just summarizes data. It asks you what your role is. I'm a nephrologist. And then it comes up with the appropriateness scoring. So in this situation, it looks like, yes, a forearm loop graft may be the most appropriate. But the one thing that I want to point out is that for this particular patient, a radiocephalic fistula probably is not the most appropriate access for this patient. So now you've chosen this access, and we know that we need to be prepared because all accesses have complications. And the most likely and problematic lesion for both fistulas and grafts is the stenosis. So for fistulas, it can contribute to non-maturation, and for grafts, we see stenosis and thrombosis. And so how do we manage this? So I'm going to talk a little bit on the data that supports the use of stent grafts. So there are many studies that you know much better than I do, the 3 Rs, the RENOVA, RESCUE, and REVISE study. And what do they tell us? They tell us information that may help us with choosing the options for managing stenosis. The bottom lines for managing graft stenosis is that there are several options. The first that the guidelines talk to us about is using angioplasty. Another option is bare metal stents. However, it's quite problematic with in-stent restenosis, and that's something that the KDOQI guidelines do not recommend. And then there's the stent grafts. And the stent graft is supported by these multiple randomized clinical trials that I talked to you about. And in the guidelines, they were limited to 6-month target access primary patency and access circuit primary patency. But the results of all of these RCTs indicate that stent graft is superior to PTA looking at the outcomes in this study. So what does KDOQI say about stent grafts? It says that there is appropriate use of self-expanding stent grafts in preference to an angioplasty alone to treat clinically significant graft anastomotic stenosis in grafts when the outcome that you're looking at is about 6 months, because that's all we had the data for. But one of the things it also highlights is that before you do that, you really need to consider the consequences of putting in that stent graft with regards to future access options and to make sure that you don't put the stent grafts in where there are cannulation segments. So what are the indications for stent grafts? I think my colleague is going to talk a little bit more about it, but they're in the guidelines in table 15.2, really looking at recurrent issues at the graft vein anastomosis in grafts. So the takeaways for stent grafts is that there is good guidance for only up to about 6-month outcomes that were incorporated in the guidelines. Stent grafts appear to be superior to PTA alone for target access pardon patency and access circuit patency at 6 months after the procedures. And the key point from the KDOQI is really use it only if the operator can properly place it and it doesn't affect the cannulation zone and after you consider the patient's ESKD life plan. You really must consider the impact on future access procedures and options. So I'm going to end my section by saying keep an open mind and properly evaluate the evidence. You know, it's really important to reevaluate it as we move forward. Vascular access superiority may be a reflection of many factors beyond the access itself. The KDOQI guidelines emphasize a patient-centric approach to vascular access choice and care, supporting the appropriate use of all access types, including grafts. And stent grafts are helpful for managing graft stenosis, to maintain patency and to fulfill the guideline targets. So thank you for your attention.